I'm Dr. Green. My specialty is internal medicine, and the topic of this lecture is going to be gout and drugs for rheumatoid arthritis. So we'll first start talking about the classic presentation of rheumatoid arthritis. So basically what we look for when we are working a patient up for rheumatoid arthritis is, are they complaining of morning stiffness? Usually the stiffness is going to last for about 30 minutes to an hour when they wake up in the morning. Second thing is symmetric joint involvement. Rheumatoid arthritis is not one of the polyarticular arthritises that basically travels and involves different joints. Most of the time, patients are going to have disease in their wrist. They're also going to have symptoms in their MCPs and also their PIPs. The dip joints are basically almost never, I mean, you can never say never in medicine, but almost never involved in rheumatoid arthritis. If they're having symptoms in the DIP joints, you probably want to put a couple of other things on your differential. And also systemic symptoms. Rheumatoid arthritis can cause fever, fatigue, chest pain. It can cause pleuritis and pericarditis. So those are some of the systemic symptoms that you want to think about. So first, we'll talk a little bit about DMARDs. And DMARDs are basically, it's a general category of drugs. There are several of them, but what they do is they all slow the disease progression. We're going to talk also about biologic response mediators, and these are a little bit different category from DMARDs, but they include the TNF inhibitors that I'm sure you've probably heard about, and there are several other drugs also that are included in that category as well. And so some of the indications for using disease-modifying anti-rheumatic drugs, that's what DMARDs are. Some of those indications are going to be, of course, rheumatoid arthritis. There's also SLE. There's Crohn's disease. There's ulcerative colitis, ITP, myasthenia gravis. There are various other diseases that these DMARDs can be used for. Typically, when you diagnose a patient with rheumatoid arthritis, you're going to start them on like an NSAID or maybe even a glucocorticoid. So what these things do, they're not DMARDs, but they will cause amelioration of the patient's symptoms a lot faster than some of the DMARDs do. A little bit later on, we'll talk about the half-life of some of the drugs, and some of these things can take weeks and sometimes months before the patient actually sees a clinical benefit. So you basically want to start them on an NSAID, or like I said, start them on a steroid, something that's going to help them feel a little bit better in a couple of days. Once you observe disease remission, you can cut down on the NSAID, and you can also cut down on the steroid. I mean, steroids have lots of side effects, so too many to name at this time, but you know, if you don't have to maintain a patient on 60 milligrams of prednisone to control their disease, you can taper them down to 5 or 10, whatever is the least dose that the patient can live with, or you know, the symptoms are not all that bad. That's a dose that you want to keep the patient on. The best time to start a DMARD is basically within the first 3 months that you diagnose a disease. And you have to think about that this whole entire time, rheumatoid arthritis is causing joint destruction, you have periarticular osteopenia, and you also have all the systemic symptoms with rheumatoid arthritis. Patients don't particularly want to live with that, so you want to make sure you get these patients on DMARDs as soon as possible. As general practitioners, it's best to become familiar with some of these DMARDs because it may take a patient, you know, a month or 2 months before they can actually get in to see a rheumatologist. So if we can do the basic things to kind of ameliorate symptoms and try to stop disease progression early, you know, we can do that for patients. So a lot of these drugs, you know, generally should be prescribed by a specialist or a rheumatologist, but some of the things like starting a patient on NSAID, starting them on steroid until they get to that point where they can see a rheumatologist, that would be good just for us general practitioners to know how to do. So let's start with the first category of DMARDs. The first one that we'll talk about is methotrexate. The half-life of methotrexate is about 3 to 15 hours, and this one is a pregnancy category X. I won't talk about the pregnancy categories on all of the drugs, but there are some that you definitely should be aware that they're teratogens. So this is one of them, category X. And the mechanism of action of methotrexate is it's a folic acid analog, and basically what it does is it inhibits dihydrofolate reductase. Dihydrofolate reductase catalyzes a conversion of dihydrofolate to tetrahydrofolate. Folic acid is needed for the de novo synthesis of nucleoside thymidine. It's also required for DNA synthesis. So basically, when you use methotrexate, you block the synthesis of purine bases, you block the synthesis of DNA, RNA, thymidolates, and proteins. Methotrexate, basically it acts during the S phase of the cell cycle, so it has its greatest effect on cells that are rapidly dividing. So it's not only the inflammatory cells that are in the joint, but you also have to think about your mucosa. So it's going to destroy some of the oral mucosa, and also it can cause some GI symptoms as well. The therapeutic uses of methotrexate, rheumatoid arthritis, definitely you can use it for that. Psoriasis, plus or minus psoriatic arthritis. Also, it's an abortifacient. We use this sometimes to induce abortions. And also when patients have ectopic pregnancies and they just haven't miscarried yet, we can use it in that setting also. Choriocarcinoma, lymphoma, and certain types of leukemias, methotrexate has been used to treat all of these things. And so some of the adverse effects, I just touched on mucositis. You can have oral ulcers, and a lot of times it might cause some nausea, some vomiting, some diarrhea from the mucositis as well. And another big thing is myelosuppression. But one thing to note is that the myelosuppression is actually reversible, and also the mucositis can be reversible if you give the patient leucovorin. So if you have a patient that is clinically doing very well on methotrexate and you're monitoring their CBC, say every 3 months, and you note that they're starting to have some myelosuppression, you want to make sure that you put the patient on leucovorin at that time, because that can actually stop the myelosuppression and you don't have to discontinue the drug, particularly if a patient is already doing well on it. When patients are on methotrexate, you always want to supplement them with a milligram of folate every day. Some of the other adverse effects of methotrexate include fatty liver, hepatitis, and pulmonary fibrosis. So when the patients come in, you definitely want to make sure that you are monitoring serially CBC, LFTs, and also if the patient is complaining of dyspnea or cough, you might want to consider doing some pulmonary function tests or chest X-ray. And the next DMARD that we'll talk about is leflunomide. Leflunomide, the half-life of this one is about 2 weeks, so it's going to take about 4 to 6 weeks before a patient can really see some amelioration of their symptoms. This one is also a category X, so it's teratogenic. You want to make sure you're not using this in a patient that's pregnant, or even for a male that's trying to conceive. There's a washout period that you have to go through with cholestyramine. So for a patient, a female, if she's taken this drug, she can't get pregnant within 2 years after she's stopped the drug. And if she does, want to get pregnant before the 2-year period is over with, you've got to go through the washout period with the cholestyramine. So the mechanism of this drug, it's a dihydroorate dehydrogenase inhibitor. And what that means is that it blocks pyrimidine synthesis, is basically what it does. And it's also got some genuine anti-proliferative activity, and also it's an anti-inflammatory agent. The therapeutic uses for leflunomide include rheumatoid arthritis and psoriatic arthritis. Some of the adverse events that you might run into with this drug. So number one thing is hepatitis. You always want to watch out for that. And also myelosuppression, aplastic anemia, and interstitial lung disease are also some of the adverse effects. You can use NSAIDs and you can use steroids also when you start this drug. But what you don't want to use are antimalarials. You don't want to use azathioprine. You don't want to use methotrexate. Patients can have severe hepatotoxicity if you add it to methotrexate or add it to one of the other aforementioned drugs. So when you use leflunomide, just remember the only other thing that you really want to use with it is either an NSAID or a steroid to bring the patient rapid relief, but no other DMARDs. Monitoring for leflunomide. You want to continually monitor their CBC and also their liver function tests. Hydroxychloroquine is the next drug that we'll discuss. This is another DMARD. The half-life of hydroxychloroquine is 1 to 2 months. So this one also, just like all the rest of the other drugs in this category, is going to take several weeks for it before the patient actually sees a clinical benefit. The mechanism of action of hydroxychloroquine, it increases lysosomal pH in antigen-presenting cells. This is a mechanism that we already knew about. We believe that that's how hydroxychloroquine actually kills cells in malaria. The mechanism of action of hydroxychloroquine in rheumatoid arthritis is basically it blocks the activation of toll-like receptors on plasmacytoid dendritic cells. The toll-like receptors recognize DNA-containing immunocomplexes, and what that does is it leads to production of interferon, and it causes the dendritic cells to mature and present antigen to T cells. So if you block that toll-like receptor, those dendritic cells aren't activating T cells. Therapeutic uses of hydroxychloroquine are rheumatoid arthritis, malaria, lupus. This one is one of the ones that you want to use for patients who have mostly skin manifestations of their disease. It works great for skin manifestations in lupus and also some of the joint pains in lupus. Adverse events associated with hydroxychloroquine, GI symptoms. Most of these drugs, you'll find that's a common thing. Most of the DMARDs cause a little bit of nausea, maybe some vomiting, and maybe some diarrhea, but patients usually tend to get over those symptoms. And also altered eye pigmentation is one of the big ones that you've got to be concerned about. Patients on this drug should have their eyes examined every year. They need a dilated fundoscopic exam because they can lose their vision secondary to the changes that the hydroxychloroquine can cause in the eye pigments. Acne, anemia, and bleaching of hair is another one that hydroxychloroquine can cause. Also blisters in the mouth and the eyes and some blood disorders also. So monitoring for this drug, just frequent eye exams is basically what you need to remember for this one. Next, sulfasalazine. This is also in the DMARD category. The half-life of this drug is 5 to 10 hours. So the onset of action for this one will be a little bit faster than some of the other DMARDs that we've already talked about. The mechanism of action. The first thing it does is really suppresses interleukin-1 and also interferon alpha. It also induces apoptosis of inflammatory cells. So this one we use in rheumatoid arthritis and also inflammatory bowel disease. Some of the adverse effects for this drug are going to be hepatotoxicity, agranulocytosis, and again, nausea, vomiting, some diarrhea. With sulfasalazine, you need to serially monitor the patient's CBC. D-penicillamine. So this is the next DMARD that we'll touch on briefly. The half-life of this one is 1 hour, so this one can actually cause symptom relief pretty quickly. It's a pregnancy category D in the United States. The mechanism of action for D-penicillamine. Number one, this is actually a chelator. This is one of the drugs that we use in Wilson's disease to increase urinary copper excretion. It decreases the number of T lymphocytes. It blocks macrophage function. It also decreases rheumatoid factor also. It also blocks collagen from cross-linking. Some of the adverse events associated with D-penicillamine include membranous glomerulonephritis, aplastic anemia, antibody-mediated myasthenic syndrome, and drug-induced lupus. So with this one, what you want to do, you make sure you monitor CBC, and you want to make sure you monitor a urinalysis also to see if patients are having any type of dysmorphic red cells, because remember I said that they can have membranous glomerulonephritis. And the last and final drug that we'll talk about in the DMARD category is the gold salts. The half-life of gold salts, they require about 2 months before they achieve a steady state and patient really starts having some clinical benefit. The mechanism of action of gold salts, this one is basically through a series of thiol exchange reactions. Gold gets absorbed into the synovial cell and it causes antimitochondrial activity and also induces apoptosis. So that's basically how it works. We use it in rheumatoid arthritis, we use it in inflammatory bowel disease, psoriatic arthritis, membranous nephritis, and also lupus. Adverse effects that you need to watch for this one include nausea, vomiting, diarrhea, and also myelosuppression. So you should monitor frequently CBCs. Just briefly, there are some other points I want to mention about the DMARDs before we move on. Number one, the two DMARDs that are typically considered first line more so than the other ones are hydroxychloroquine and methotrexate. By and large, when patients come in with rheumatoid arthritis and they're newly diagnosed, Just about every patient gets either methotrexate or they get hydroxychloroquine, and then you want to basically monitor the patient's symptoms based on those medicines, and then you add things if you need to. So with DMARDs, when patients discontinue therapy, there's a phenomenon called rebound flare. And what this means is that the patient's symptoms become a little bit more aggressive. And even if the patient was previously in remission on the drug, when you restart the drug, there's no guarantee that the patient will go back into remission.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
I just needed a warm-up.
Maybe later, Sal. Now it's time for the mnemonic for the anti-rheumatic agents. CHAMP. C-H-A-M-P. Like me. CHAMP.
Cyclosporin,
Hydroxychloroquine, Oranafin, methotrexate, and penicillamine. CHAMP.
Chump.
No, CHAMP.
Chump.
CHAMP.
Chump.
CHAMP. The
You're
word
a
is
chump.
CHAMP,
No, yeah,
you
but
sore
you're a
loser.
chump. I'm just
Maybe
telling
if
you
you
what
spent
you
some
are,
more
and
time
that's a
at the
chump.
gym and not at the hussy bars.
You don't bite me, nerd.
Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. It's time for your quick review number 1. Let's get started. Patients are sometimes started on a steroid along with their DMARD medications to give them relief of symptoms faster. What are some adverse effects of a long-term steroid use? Well, there's a lot of them. Osteoporosis, you definitely get some bone breakdown with the glucocorticoids. Increased risk of infection, increased appetite, so patients generally gain some weight. Emotional disturbance, and that can be dramatic. You can even have psychosis. You can get steroid rage from glucocorticoids. People will really flip out. Kids can get super hyper. I've had patients who the parents weren't very happy with me. I had to use a steroid for whatever reason, and the kid didn't sleep all night and just drove everyone nuts. Hypertension is another big one. Peripheral edema, peptic ulcer, hypokalemia, and then of course high blood glucose. If someone's on steroids long enough, you are going to induce diabetes. Next, what is the pregnancy category for methotrexate and leflunomide? So, very important to know your Category X medications. There are a few that are going to crop up over and over again in your career. Leflunomide and probably more commonly used methotrexate. Category X, do not use them. You will induce teratogenic problems. How can you reverse some of the adverse effects seen with methotrexate, such as mucositis and myelosuppression? Well, you can give the patient leucovorin. So leucovorin helps decrease that anti-folic acid effect that's going on with your methotrexate. Next, leflunomide should not be used with what other medications because of an increased risk of hepatotoxicity. So anti-malarials, azathioprine, and methotrexate. So most of the time when you're using that medication, try to stick to your steroids or to your NSAIDs. Why is it important for patients to get yearly eye exams when taking hydroxychloroquine? Well, this medication can cause altered eye pigmentation, and this can eventually lead to vision loss, so very important. A patient presents with progressively worsening liver function tests, a prolonged prothrombin time, and a low ceruloplasmin level. What disease does this patient have? Which DMARD could be used to help treat this problem? So the ceruloplasmin level is what gives this away. This is going to be Wilson's disease, so they have too much copper running around in their body. And what do you use? D-penicillamine. One way to remember this is that pennies are made of copper. So copper, Wilson's disease, penicillamine, that's the way to remember that one. A patient with newly diagnosed systemic lupus erythematosus has multiple skin lesions. Which DMARD would be appropriate for this patient? Remember, hydroxychloroquine, great for skin manifestations. It's also used for other inflammatory disorders that cause a lot of skin, things like sarcoid. I've had several patients with very, very impressive sarcoid lesions, especially on the nose, that got remarkably better on hydroxychloroquine. So remember hydroxychloroquine and skin. What are the two most commonly prescribed DMARDs for a newly diagnosed patient with rheumatoid arthritis? So this is a pretty easy one. Think of methotrexate. Think of the one we just talked about, hydroxychloroquine. Now, oftentimes patients might be on more than one medication, or they fail this one, or they don't tolerate it. But think of those two medications. They're very commonly used. When discontinuing a DMARD, it is important to warn your patient that they may experience what? So this is a rebound flare. So you keep people immunosuppressed for a while, and they get used to a certain way of feeling, and then boom, it comes back with a vengeance. So let them know about those potential symptoms that are going to come back on them. What is the mechanism of action for methotrexate? So this is a folic acid analog. It inhibits dihydrofolate reductase. So this blocks purine, DNA, RNA, thymidylate, and protein synthesis. What are the adverse effects of D-penicillamine? So this can cause membranous glomerular nephritis, aplastic anemia, antibody-mediated myasthenic syndrome, and drug-induced lupus. All right, so that's going to finish our quick review number 1. Let's go back to the lecture.
So now we'll move on to biologic response modifiers. And from now on, you might just hear me refer to these as biologics. So what biologics do is they selectively target a pathologic element of the disease. Most of these that we're going to talk about, 3 of the 5 that we'll be talking about are TNF blockers. So I think I should just take a moment to mention what TNF is and what it does in the body. So TNF is a cytokine that's produced by monocytes and also macrophages. It mediates the immune response by increasing the transport of white cells into sites of inflammation. It also increases pro-inflammatory cytokines, particularly interleukin-1 and interleukin-6, which enhance leukocyte migration from the blood vessels into the tissue by increasing the permeability of the endothelial layer of blood. And it also causes increased release of adhesion molecules also. All TNF inhibitors, all of them have one basic side effect that you'll have to remember. There are only 3, but you just need to know that any 3 of them can cause immunosuppression. There are also some seronegative spondyloarthropathies which are typically treated with anti-TNF agents also. Those are psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and Reiter syndrome. And the mnemonic for that is PAIR. So remember, P-A-I-R, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and Reiter syndrome. All right, so we'll get started and we'll talk about the first one. The first anti-TNF drug that we'll talk about is etanercept. The half-life of etanercept is about 70 to 132 hours. It's a pregnancy category B, so that's a good thing. You can use this in pregnant patients with rheumatoid arthritis. The mechanism of action for etanercept, it's a recombinant TNF receptor that binds to soluble TNF. So one of the basic things that we'll talk about really quickly is that TNF is actually present in a couple of forms. It can be soluble and it can also be transmembrane. Etanercept blocks soluble TNF. We use this for rheumatoid arthritis, ankylosing spondylitis, psoriasis, and also Alzheimer's disease. There's a pilot study that showed a small but significant improvement in various cognitive rating scales in patients with Alzheimer's disease after etanercept. So there are some patients, there are some clinicians that use etanercept in Alzheimer's disease, and patients are paying between $10,000 to $40,000 to be treated every year with etanercept for Alzheimer's disease. The adverse effect that you really want to think about, again, like I said, with all of the anti-TNF agents is immunosuppression. So infliximab's mechanism of action. It's a monoclonal antibody against TNF alpha, and this one is actually a chimeric antibody. It's human and also mouse antibody. It fixes complement and causes apoptosis of TNF-expressing activated T lymphocytes. It binds to both soluble and transmembrane TNF alpha. We use this one in rheumatoid arthritis, we use it in psoriasis, and we also use it in Crohn's disease. You can use infliximab in stricturing, penetrating, and inflammatory Crohn's disease. Adverse effect, immunosuppression. So basically, granulomatous diseases need TNF so that they can form granulomas. Without TNF, you'll have reactivation of granulomatous diseases. Number one is TB. Anytime you put patients on these TNF inhibitors, you always have to check a PPD and make sure that they don't have latent tuberculosis that first needs to be treated before you put them on one of these drugs. Also, reactivation of hepatitis B is another big adverse event. Drug-induced lupus for this one, and also demyelinating CNS disorders. Anybody with a history of multiple sclerosis or any other type of demyelinating CNS disorder cannot use anti-TNF therapy. Another point that I wanted to mention about this is that when you put patients on infliximab and you use intermittent therapy, it increases the likelihood of developing antibodies to infliximab. This will happen in about 60% of patients. So basically what we do in order to decrease the risk of that is we're going to use maintenance therapy with infliximab instead of intermittent therapy, and also when you combine it with methotrexate, that brings the likelihood of patients developing antibodies to infliximab down from 60% to about 15%. Adalimumab, this is the last TNF blocker that we'll talk about. Half-life of this one is about 20 days, so it might take 2 months or so before this one actually starts to kick in and the patient actually sees some clinical benefit. The mechanism of action of adalimumab, it binds to TNF alpha at receptor sites. It's a fully monoclonal human antibody. It fixes complement and also causes apoptosis of TNF-expressing activated T cells. We use this one in rheumatoid arthritis, ankylosing spondylitis, psoriasis, Crohn's disease, and also juvenile idiopathic arthritis, which was formerly called JRA. And again, the adverse effect of this one is immunosuppression. So when you think about your TNF and TNF blockers, etanercept, I kind of think of it as in a separate group, and then adalimumab and infliximab, I kind of put these in the same, because adalimumab and infliximab, what they do is that these are the two that can fix complement and actually apoptose cells. Etanercept does not. It's still a TNF blocker, but it doesn't fix complement and it doesn't cause apoptosis of cells. So that's one thing that you should remember about those drugs. So we'll talk about biologics that aren't TNF inhibitors. The first one is anakinra. The half-life of this one is about 6 hours, so you should get clinical benefit a little bit earlier than some of the other biologics. And this one is a category B, so again, this one is one you can use in pregnancy. Its mechanism of action is that it's an interleukin-1 receptor antagonist, and basically what this does is this decreases inflammation and cartilage degradation that can be associated with rheumatoid arthritis. It also decreases bone resorption, so those are two of the major things that happen in the joints with rheumatoid arthritis. I mean, you get cartilage degradation, and you also have the periarticular osteopenia from the bone resorption, and it blocks both of those steps. The adverse effects are GI-related symptoms, nausea, vomiting, diarrhea, but also immunosuppression with this one as well. You want to use this as monotherapy or in combination with DMARDs. You can't use this one in combination with an anti-TNF inhibitor. It's too great of a risk of immunosuppression. Serially, you want to monitor the patient's CBC just to make sure that their bone marrow is not suppressed. The last and final biologic that we'll briefly touch on is abatacept. This is a pregnancy category C drug. Half-life is about 13 days, so it'll take a couple of weeks before patients see some clinical benefit from this one. The mechanism of action, this one blocks co-stimulation of T cells. If you dig way back in your memory bank, you might remember that When a T cell is activated, it basically needs two things. Number one, it has to have the antigen-presenting cell present an epitope in the form of an MHC, but also, aside from that, it's got to have co-stimulation from that antigen-presenting cell, and this is what abatacept does. It binds to B7 protein on antigen-presenting cells and blocks them from delivering the co-stimulation to T cells. We use this one only in rheumatoid arthritis. Some of the adverse effects, immunosuppression, and it can also be oncogenic. Abatacept is one of the drugs that you only want to use if a patient has had inadequate response to one or more DMARDs. Rituximab is also a biologic. Its half-life is 30 to 400 hours, so very, very variable. And this one is a pregnancy category C. The mechanism of action of rituximab, so it's a monoclonal antibody against CD20, and CD20 is a B cell surface protein. So basically what it does is it destroys both normal and malignant B cells that have CD20 on their surface. We use this one for rheumatoid arthritis, we use it for ITP, vasculitis, SLE, and also autoimmune anemias. Some of the adverse events, cardiac arrest is rare, but this one is a drug that is infused, so it can cause anaphylaxis, also cardiac arrest. It can cause tumor-lysis syndrome, reactivation of Hep B, can cause PML, immune toxicity, and also pulmonary toxicity. So rituximab is a little bit like abatacept in the sense that we basically only use this drug when patients have been unresponsive to one or more DMARDs, but also in this one they have to have been unresponsive to one or more anti-TNF inhibitors. Next, we'll discuss gout and some gout medications. The first three that we'll talk about are indomethacin, steroids, and colchicines. These are the ones that we use to treat acute gouty attacks. The drug of choice for treating gout is indomethacin, unless the patient has a history of renal insufficiency, then we might have to consider steroids. Indomethacin is an NSAID, and it puts the patients at increased risk of GI ulcerations. So what we can use to counteract that is misoprostol. And what it is a prostaglandin analog that augments the generation of gastric mucus barrier, and it also inhibits gastric acid secretions. So when you use NSAIDs to treat gout, as I've said, indomethacin is basically the drug of choice. What you don't want to use is aspirin. Aspirin, particularly if you take it at doses less than 2.6 grams a day, aspirin competes with uric acid for secretion in the proximal tubule. So instead of uric acid being secreted, aspirin is actually secreted. And so that means that the uric acid concentration in the blood will remain high. The indication for gout prophylaxis, there are basically 4 things that would prompt you to want to use prophylactic measures in patients who have gout. So if they have greater than 2 gouty attacks per year, if the attack is very severe, or if the patient has kidney stones. If their serum urate is greater than 10 milligrams per deciliter, the goal for patients with gout is to keep their serum urate less than 6. And also if their urinary urate excretion is greater than 1 gram in 24 hours. Some of the medicines that we use to prevent gout occurrence. So one is allopurinol, number 2 is probenecid, and actually colchicine can also be used for prophylaxis as well as treating acute gout. And we'll first start our discussion over gout drugs by talking about colchicine. So colchicine is a spindle poison, if you will. And in doing that, it inhibits neutrophils from undergoing mitosis, and also it inhibits them from being able to migrate to sites of inflammation. So that's basically how it has its anti-inflammatory effect. When the tissue pH is too high, it retards crystal formation in the joints. Some of the adverse effects of colchicine: GI upset, severe GI upset. That is actually one of the indicators that we use to stop colchicine when we're treating somebody acutely for a gout attack. When they have so much nausea, so much vomiting, so much diarrhea, that's when we decide that it's time to discontinue it. The next thing is neutropenia. It can also damage your bone marrow. Severe neuromyopathy may result in patients with chronic kidney disease. You don't want to use this in a patient with renal insufficiency because that can actually be irreversible. We use this both in acute and in chronic gout. So again, when we have a patient with an acute gout attack and you use colchicine initially, we continue to dose the colchicine until one of three things happens, either until the patient has symptom relief, or until we've reached our maximum dose achieved, or until the patient presents with diarrhea. And there's no antidote to colchicine, so you want to make sure that when you have reached your goal, you discontinue the medicine, because if you overdose a patient with colchicine, the treatment is basically supported. There is no antidote. Allopurinol. This one has a half-life of about 2 hours and is a pregnancy category C. The mechanism of action of allopurinol is that it's a xanthine oxidase inhibitor, and in doing that, it decreases the conversion of xanthine to uric acid. So some of the uses for allopurinol are chronic gout. We also use it in patients who are being treated for leukemia and lymphoma, because we can also present urate nephropathy in patients that are undergoing treatment because they will get sometimes tumor lysis syndrome. The adverse events associated with allopurinol: hypersensitivity syndrome, fever, skin rash, eosinophils, and hepatitis are some of the clinical manifestations of this hypersensitivity syndrome. Renal failure is also another one that it can cause, and also Stevens-Johnson syndrome and TEN. So don't forget those two, allopurinol. Always associate that. If somebody has a rash and they're on allopurinol, they have mucositis, always associate that with Stevens-Johnson's or TEN. So we'll briefly talk about indomethacin. Indomethacin is a non-selective COX-1 and COX-2 inhibitor. It is a type of NSAID. We use indomethacin. This is actually the drug of choice in acute gouty attacks, and also you can use this for closure of the patent ductus arteriosus. The adverse effects associated with indomethacin, number one, is just basically GI symptoms. It's less toxic than colchicine, but you also can't use this one in patients with renal insufficiency. You really want to stay away from the NSAIDs. The next drug is febuxostat. This one was actually recently approved by the FDA for treatment of chronic gout. So it's a non-purine selective inhibitor of xanthine oxidase. And some of the side effects are just basically GI related. Pegloticase is also another drug that we're using to treat chronic refractory gout. This one actually got FDA approval back in September of 2010. So it's a pegylated uric acid specific enzyme. And some of the adverse effects that can be associated with this one are GI symptoms and infusion reaction. Lastly, we'll talk about our uricosuric agents, so probenecid and sulfenpyrazone. So both of these drugs inhibit reabsorption of uric acid, and they do this competitively in the proximal tubule. There's an organic anion transporter that binds uricosuric agents preferentially, and it prevents them from reabsorbing uric acid. Again, probenecid and sulfenpyrazone are both used for treatment of chronic gout. The side effects associated with probenecid, they're very rare, but occasionally patients can report dizziness, hair loss, and a rash. For sulfenpyrazone, it's basically GI symptoms that patients complain about. And some interesting history, probenecid actually interferes with excretion of penicillin. So they used this in World War II. Penicillin was in such limited supply, they had to figure out a way to increase the half-life. So they used probenecid to stop the excretion of penicillin. Probenecid can occasionally encourage a gouty flare. When it's not in a therapeutic range, it can actually inhibit renal excretion of urate and worsen your gout. You only want to use probenecid at higher doses to prevent that. When you first start a patient on probenecid, in order to prevent an acute gout attack, you might want to actually start them on an NSAID as well. You don't want to choose aspirin as the NSAID that you put the patient on, because it will actually inhibit the desired effect of probenecid. And for patients undergoing treatment for leukemias and lymphomas, as we kind of touched on briefly a little bit earlier, they can have tumor lysis syndrome, and the tumor cells will actually release a lot of urate, which can end up causing urate nephropathy, we use allopurinol or febuxostat to prevent that. The only corollary to that is that when you use the chemotherapeutic agent mercaptopurine, xanthine oxidase inhibitors should be avoided because they actually inactivate mercaptopurine's chemotherapy properties. And so this is basically a kind of a board review question. Some of the medications that are known for causing Stevens-Johnson syndrome: number 1, allopurinol; number 2, seizure drugs; next, sulfa drugs, and also Cillins.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Why don't we start allopurinol during an acute attack of gout? Changes in uric acid levels may worsen or prolong an acute attack. Do you want that on your conscience? With doctors like you, it's no wonder the malpractice lawyers are getting richer and richer.
Okay, we're back. Now it's time for quick review number 2. Let's get started. How do tumor necrosis factors work? Well, these are cytokines produced by monocytes and macrophages, and they mediate a lot of immune responses by increasing the transport of WBCs into sites of inflammation. Now, they can also increase pro-inflammatory cytokines, specifically interleukin-1, interleukin-6, and this will enhance leukocyte migration from the blood vessels into the tissues by increasing the permeability of the endothelial layer of the vessels. So, real important. It's basically just increasing the overall inflammatory process. And then this last one here increases release of adhesion molecules. Next, TNF inhibitors have a variety of adverse effects, but they all share one common adverse effect. What is this common effect? Well, this is immunosuppression. So anytime you're using these medications, you have to expect these people to get infections more easily, or very importantly for our next question, infliximab can cause reactivation of blood diseases. So it's immunosuppressing, so you have to worry about tuberculosis and you have to worry about hepatitis B. And if you're going to start one of these medications, you need to check a PPD or a TB screening test. And if it's positive, you need to make sure that either they've been treated for latent tuberculosis or, heaven forbid, they have active tuberculosis. And you wouldn't want to give them this medication either. But remember, you always have to get a PPD before you start these TNF inhibitors. How do you prevent patients from developing antibodies to infliximab? Well, you can use a maintenance therapy instead of an intermittent therapy, and you can also combine it with methotrexate. Next, which TNF inhibitors fix complement and cause apoptosis of cells? Well, that's the infliximab we've been talking about, and adalimumab as well. What is the first-line choice for the treatment of acute gout? There's lots of treatments for gout. If you read an article on it, you're going to get a long article. But there's lots of different opinions on this. And what's interesting about gout is that there's a lot of information about what you should use, but there's not a lot of good trials to tell you which one works the best. So it's generally accepted that the NSAIDs are used most often. And what gets quoted more often than anything is indomethacin. But there's really no data that supports indomethacin over any of the other NSAIDs. So by all means, you can use indomethacin. There's nothing wrong with it. But I tend to tell people, well, do you have naproxen at home? Because they sometimes will call me, I'm having a gout flare-up. What do I do? I'm all out of my indomethacin. Well, there's nothing magic about indomethacin. You can get one of the more high-potent NSAIDs like naproxen and take it twice a day, and you're going to get the same effect as taking indomethacin. So don't be cornered into, well, gosh, indomethacin is the only thing that can treat acute gout. All the NSAIDs are effective. You might want to use a little bit higher dosages than the minimum dose. So naproxen, 500 milligrams twice a day, can be very helpful. Next, how does misoprostol work to avoid GI ulcerations in patients taking indomethacin? So This will augment the generation of gastric mucus barriers. So it inhibits the gastric acid secretions as well. So it's helping to kind of form a kind of viscous mucus barrier, and it helps prevent ulcerations due to NSAIDs. What are two important adverse effects of allopurinol to remember if a patient on allopurinol presents with a rash and mucositis? So allopurinol is one of the few drugs that can cause Stevens-Johnson syndrome, so that's a big one. And then toxic epidermal necrolysis, or TEN, is also a possibility as well. What else can cause Stevens-Johnson syndrome? Well, there's a long list, but the short list that maybe it's good just for remembering is remember antibiotics. So you want to remember your sulfa drugs, you want to remember your penicillin drugs, and then you want to think of your seizure drugs. So seizure drugs, penicillin, sulfa drugs, and allopurinol are the big ones to remember for Stevens-Johnson syndrome. Next. Which class of drugs will inhibit mercaptopurine's chemotherapy properties and therefore should be avoided in patients on mercaptopurine? So these are your xanthine oxidase inhibitors, so you don't want to use allopurinol when someone's getting chemotherapy with mercaptopurine. Next, how should you initiate chronic allopurinol therapy in a patient in an acute gout attack? So this is a very important issue. Someone comes in, this is like their third gout attack this year, and they're like, forget it, I'm done treating this intermittently. I want to be on chronic suppressive therapy. I want to take the medication so I don't get gout anymore. So you're going to think, aha, you should probably be on allopurinol. That's the most commonly used medication for long-term suppression of gout. And why don't we just want to start this right now? Well, he's in an acute gout attack, so you don't want to start allopurinol in someone who's in an acute attack. You want to control the symptoms first before you ever think about starting allopurinol. So the first thing you're going to do is control the attack with NSAIDs, or you can also use colchicine. And then you're going to continue that NSAID or colchicine for sometimes up to 6 months while you're initiating that allopurinol treatment. So why do you do that? Well, allopurinol theoretically can worsen a gouty attack. So someone who maybe just barely gets their symptoms under control, you put them on allopurinol, you take away the NSAIDs or the colchicine, and then boom, they're right back into an acute gouty flare-up. So you have to suppress the flare-up for a good long time and then continue that suppression or prophylaxis for about 6 months while you're initiating the allopurinol treatment. Next, what other measures can help decrease gouty attacks? So people have an increase in uric acid in their body. How can they decrease that hyperuricemia? So first thing is weight loss. There's an increased amount of uric acid in obese patients, so decreasing weight in general. Decreasing alcohol consumption can certainly decrease your uremic concentration in the blood. Diuretics are an important thing to remember. You might get a question on that, especially thiazide and loop diuretics. You hear it a little bit more with thiazide diuretics, but loops can do it as well. And then low protein diet, so decreasing the amount of like red meats that you're eating. Seems to be okay if you're eating more kind of dairy based proteins, but red meats tend to increase your uric acid as well. All right, so that's going to conclude our quick review number 2. Now is a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together. All right, we've made it to the end. It's time for the end of session quiz. Let's get started. Probenecid and allopurinol are used in the treatment of chronic gout. How do their mechanisms of action differ? Well, allopurinol inhibits xanthine oxidase. So this is the enzyme that catalyzes the conversion of purines from hypoxanthine to plasma uric acid. Now, probenecid inhibits the tubular reabsorption of uric acid. So allopurinol decreasing the production, probenecid inhibiting the reabsorption of uric acid. Next, which drug used for rheumatoid arthritis predisposes patients to respiratory tract infections? For example, reactivation of latent TB. So for the reactivation of latent TB, when we put that there, we're thinking of our TNF inhibitors, so infliximab is one. But realize that most of the medications we use for rheumatoid arthritis can cause immunosuppression and increase the susceptibility to respiratory tract infections. So don't be fooled that the TNF inhibitors are not the only ones. Almost all of them do, so be on the lookout for anyone being treated for rheumatoid arthritis that they're going to be immunosuppressed. Which agent has the following mechanism of action? So irreversible inhibition of cyclooxygenase, that's going to be aspirin. Inhibits dihydrofolate reductase, methotrexate. Reversibly inhibits COX-1 and COX-2, that's going to be most of your NSAIDs, other than aspirin. And binds to tubulin and blocks cellular function, that's going to be colchicine, and inhibits xanthine oxidase, that's allopurinol. Next, how can you differentiate gout from pseudogout from septic arthritis? So this is a tough question, or a tough clinical question when you're faced with it. So you have someone who comes in, they have a single hot, swollen, red, painful joint, and your job is to figure out what's going on in there. I always have in my mind a big, swollen, red knee. So it's a little bit difficult to tell. Now, people who have septic joints, they've got some bacteria in there, it's infused their whole joint, it's terrible. They're going to have pain with micro movement. Now, sometimes it's hard to tell because people have a lot of pain with gout and pseudogout as well. But I try to imagine the tiniest movement of a joint. People are holding their leg. They don't want any movement. That's what I think of more with a septic joint. But that's really not enough to go on to place your diagnosis on septic versus gout versus pseudogout. So really the only thing is arthrocentesis. You got to stick a needle in there and aspirate and look for either lots of white blood cells, and when you have a septic joint, you're going to have something over 50,000 white blood cells going on in there. Now you can have some increased WBCs as a result of the inflammation from gout and pseudogout, but you're going to look for the different crystal formations for your gout and pseudogout. So ultimately, if you don't know, you got to stick a needle in there. But here's another but. There's always a but. If you can, try not to inject through red skin. So a scenario you think of is, well, someone doesn't have a septic joint, but they have cellulitis overlying the joint. You take a needle, you go through the cellulitis, and boop, there you go. Now you've got a septic joint because you've introduced infection into a normal joint. So if you can, look for non-red skin. Most of the time, if someone's going to have a lot of pain if they have a septic joint, so if they're moving that joint all over the place and you're like, well, I better tap this thing to make sure it's not septic, it's probably not septic. If they're able to really move it and not have a lot of pain, the likelihood of a true septic joint is pretty low. Moving on. A 24-year-old woman is taking methotrexate for control of rheumatoid arthritis. What are some important patient education points to discuss? Well, first, the expectation. So methotrexate doesn't cure rheumatoid arthritis. It slows down its progression. Now, it's very good, and you could potentially have less symptoms and have normal lifespan and all that type of stuff, but you're still going to have some degree of disease floating around in your joints. Now, also, the response is relatively slow. So the response can occur 3 to 6 weeks after the start of treatment. So it's not like they take the medication, whoo, I should be cured, and get frustrated and then throw the pills out the window. Then you have to talk about common side effects. So mucosal ulcerations, nausea. You can have an increased chance of infections, liver cirrhosis. You shouldn't drink alcohol. And there's going to need to be periodic blood testing. So you're going to check your CBCs, your liver function tests. So let people know this is a long-term medication. There are some side effects. It will require blood. And if people are willing to tolerate that, and if their rheumatoid arthritis is bad enough, then they'll go, sure, let's do it. Next, which chronic gout therapy is associated with Stevens-Johnson syndrome? So we've talked about this before. This is allopurinol. It's rare. I've never seen it in allopurinol. And remember, what are the other drugs that cause Stevens-Johnson syndrome? The short list. Remember, seizure drugs, penicillin drugs, and sulfa drugs, in addition to your allopurinol. Next, what medications are considered first-line treatments for rheumatoid arthritis? So first, we try to use things like NSAIDs, and you can also use Tylenol. You can use Tramadol, which is a non-opioid opioid. Which is nice. You can use opiates for PRN pain. We try not to use opiates if we don't have to. And then we start using the DMARD. So we're going to slow the rheumatoid arthritis progression. You can use the biologic response modifiers as add-ons or after failure of your DMARDs. Those are your first-line treatments, but mainly think of if they have mild disease, start with the non-steroidal anti-inflammatories first. When is infliximab indicated for a rheumatoid arthritis patient, and why is it not used as solo therapy? Well, you add this to a methotrexate regimen most of the time when you get an inadequate response to that methotrexate. And it's not used solo because the body can develop anti-infliximab antibodies. Next. Which drugs are most commonly used to treat gout in the acute state? We've talked about this several times now. What can be used if the patient has renal disease? We haven't talked about that yet. So NSAIDs. Remember how we talked about indomethacin gets all the fame and glory, but just about all NSAIDs except for aspirin. You don't want to use aspirin; that can make things worse. And then colchicine. One thing we haven't mentioned about colchicine is how it's prescribed. There is sort of a historical way of prescribing colchicine and maybe a new modern way of doing it. But colchicine in the past was used in such a way where you were supposed to take 2 pills when you get your prescription, and then 1 pill every hour until you reached about 4 grams or 4 milligrams, or you got to terrible diarrhea or nausea and vomiting. So it was one of those things that either your symptoms got better or you didn't tolerate the medication. And it tended to work okay, but everyone would get the severe side effects of diarrhea. The newer way of doing colchicine is usually we just take 2 pills initially and then 1 pill after an hour, and then you just kind of wait and see what happens, rather than adding on those additional medication dosages. So, but you are going to probably see that prescribed that way out in the clinics and other physicians. But realize there's not a great deal of benefit in really pounding the colchicine. It does work, but it probably would have worked anyway, doing it that kind of initial 2 pills in the beginning, the 1 pill an hour later. So, and again, NSAIDs you're going to use either 2 to 3 times a day, depending on which NSAID you use. The second part of the question here, what can be used if a patient has renal disease? So this is a tough one. NSAIDs aren't great. Say if you have someone who has severe renal disease, you don't want to use NSAIDs in someone who has severe renal disease. Colchicine is sort of in the same category. You don't want to use colchicine with people with renal disease. So what does that leave you with for acute gout? Well, you can use glucocorticoids. There's a couple different ways you can do them. Now, if they just have one really bad gouty joint, you can get someone who's really good at sticking needles in the joints, and you can do a local injection of glucocorticoids. Or you can take them systemically. You can take them orally, and I've had to do that a few times in the past where I have someone with some sort of nephropathy, and I'm like, well, I don't feel good about giving them NSAIDs, or they've failed NSAIDs before and they've had acute renal failure. Then you can use steroids. Of course, you can get into a horrible situation where you have someone with diabetic nephropathy, and then you're like, well, if I give them glucocorticoids, then I'm going to increase their sugars, and then that's just the fun part of medicine, is just coming up with solutions to disasters. But remember that glucocorticoids can be used in those renal patients, and then hopefully you can get them off the steroids relatively quickly before you get any of the side effects of steroids that we've talked about earlier in this lecture. Next. What is the indication for gout prophylaxis? So when you're counseling your patients on, well, doc, should I be on a pill every day to prevent my gout? And some of it comes down to the patient. So the usual indications are greater than 2 gouty attacks per year. If their first attack is very, very severe or complicated with kidney stones. If their serum urate is greater than 10 milligrams per deciliter, that one's sort of an iffy one in my book. You'll find if you read on the subject that urate levels don't correspond very well with symptoms. That there's some people who get symptoms at relatively low urate levels, and you have some people who have relatively high urate levels and they don't have any symptoms at all. So I don't necessarily go by urate levels most of the time when I'm considering a long-term prophylaxis for gout. And the last one, urinary urate excretion greater than 1 gram in 24 hours. I find that most of the time it comes down to how severe of an attack it comes and how often. And most of the time that's going to be dictated by patients. I have some patients who have one episode of gout and they're so traumatized by it that they're like, you give me anything, I'll take it every day, and I don't want gout. And then I do have people who get gout a couple times a year and they're like, I don't really want to be on a long-term medication. And you're not going to convince them otherwise. So those are the 2 big ones. The urate level, remember, doesn't always correspond very well with symptoms, so be aware of that. All right, so that's going to be the end of it. We finished our end of session quiz. I hope you learned a little something. Good luck studying, and that's the end of our lecture.